good. Thank you.
Oh, you're welcome.
Okay, well, we'll get started. Welcome everyone to the Voice Changes in Parkinson's Disease webinar. I am Casey Kasparic from Parkinson Foundation, Western Pennsylvania, and David Von Hofen and Christine Haythorne are joining us as well from Parkinson Foundation, Western Pennsylvania. And I'm very excited to introduce you to our presenter today, Tracy Thomas. And just a housekeeping item. If everyone can please mute themselves at this time, that would be wonderful. And then we'll have time at the end for questions and answers. Tracy Thomas is a speech and language pathologist, a native of Western Pennsylvania, and she's enthused to offer private voice and speech therapy services. Tracy's career in speech language pathology began in the area of brain injury rehabilitation and progressed to specialized treatment of the voice and related upper airway disorders. Tracy joined the University of Pittsburgh Voice Center in 1997, where she worked as a voice specialist for 23 years. More recently, Tracy started her own practice, Advance Voice and Speech Therapy. Tracy's love of music and drama lend well to her 30-year career in speech language pathology. So we're really thankful for your time, Tracy. And just to give you a quick overview of the webinar today, it will last for approximately 1 hour. And Tracy will be conducting a presentation for about 45 minutes, and then there will be time for questions. And at that time, we'll ask you to use the chat box at the bottom of your screen, in which you can type in the questions. And please make sure when you're typing that it says to everyone so that I can read the questions from there. So without further ado, we'll hand it over to Tracy, and thank you for your time and enjoy.
Thanks, Casey, and thanks, David.
Welcome.
I'm thrilled to be here today to speak with all of you. And as Casey said, I started my career in speech language pathology and brain injury rehab as a speech pathologist. I worked in New England. You've probably heard of Kennebunk and Kennebunkport, the area where the Bushes have their vacation home there. And that is where I made my home for the first 3 years of my career, working at a small rehab hospital there. I went on to work with Health South Corporation, and then quickly made the transition into voice and upper airway rehab, which I have specialized in for the past 23 years of my 30-year clinical career. I just opened my private practice last March. I started out kind of laying the groundwork for that, and I was able to open this summer. Which is really thrilling for me now at kind of the midlife stage, to be on my own and to be able to offer people very specialized treatment. And Parkinson's disease and the communication challenges that come with it is one of my specialty areas. So without further ado, I'd like to get into my presentation. Can everyone hear me? If you can't, if you could type a message to Casey or David and let them know. I think my audio is good, correct? Okay. And so the other thing that I want to do is kind of offer this up by way of confidentiality. I know that this is being recorded as a presentation so that people can view it later. I would ask that if it's viewed, that it not be recorded or photographed or reproduced in any way because of branding and copyright laws. Also, there is a video. If we have time to pull that up and look at it, because of HIPAA laws, it would be important that none of the content of this is shared. So I do not have a direct financial relationship and no financial disclaimers for the treatment that I give, which is called Speak Out Therapy for Parkinson's disease. I do not receive any compensation or any financial gained from advertising or using the program of Speak Out, which originated in Richardson, Texas. I use that program because I've seen results. So I just want to make that financial disclaimer. There is no reason for me to advertise or promote that program other than what I know about it clinically. So without further ado, let's get started. We have several areas that I'd like to talk about. The first being basic anatomy for communication and voice. So before we actually get started, I want to, oops, for some reason, I'm sorry, give me just 1 second. I'm having one problem here. Okay, it looks like my screen has kind of frozen, so I'm going to getting that unstuck, and then we'll move right along. Sorry, I actually have a new system that I'm using in it. Okay, so it looks like that worked. And then I have a first slide here just very quickly with one of the heroes in Parkinson's research and definitely experiencing the disease himself, Michael J. Fox, who says, "The message is so simple, yet it gets for." So I in no way consider myself an expert. I have training, but everything that I've learned about Parkinson's disease, I've learned from the wonderful people that I treat. And you all and your families know how that works. Okay, so the first thing that I want to really impart in this presentation is that neurological changes can cause speech and voice changes, and that early intervention is best. We will go back to that thread again at the end, because no matter the information that I give you, I want you to kind of keep that as a common thread, not only in your mind, but as a takeaway point from this presentation. So neurological changes can cause speech and voice changes, and early intervention is always, always best. So if we take a look at the dynamic process of speech and voice, it's very important to look at that from a top-down component, with the brain being the regulator or the modulator, so to speak, for the dynamic process, which is speech and voice. So I have some parameters of what we know happens during the motor execution of speech and voice and how that's controlled. I do not have these on the specific parts of the brain that they employ because it got very busy. So I just kind of circled these around the graph of the brain, and you should see a picture of a brain on the slide. And we'll start in the bottom left corner with coordinated movements, which all happen very rapidly as information is processed, and then as the brain signals to the communicatory muscles and systems that promote voice and speech. All of that goes through processing. There's an activation where the muscles are activated. There's timing, there's regulating of that, definitely decoding and encoding signals that are sent from the nerves to the muscles. All of that goes through the synapse of the nerves, which communicates to the muscles and then ends up with rapid timing of movement. Then there's an awareness and adjustment that occurs that we'll talk about in a minute, which we call feedback. So all of these processes start in the brain, are funneled through the systems of the brain, and these are just some of the components of that activity. So now looking at the anatomy for voice and speech, the slide that you see, I'm going to start from the bottom of that because we think of the respiratory system as the power source for the voice and for speech. The respiratory system is what drives the system. And then if you look at the green circle, you'll see a little area in the throat, and that's the larynx or the laryngeal system, where we have the voice, the actual vocal folds, which is the top of the airway. The final piece is the modifying source for all the sounds of speech and all of the voice components of communication. That's the resonating chamber, which also contains the articulators. So if we think of this as three systems that work in a dynamic way together, I'm going to talk a little bit about each one. So keep in mind how that bottom is the power. The middle layer is the source for sound, or I will refer to that as the vibratory source. And then the red circle comprises the resonating chamber, or the articulation and the modification of the shape and the sound. So let's look more at the power source. This is what I refer to as the respiratory system. This is not all-inclusive, but for our discussion today, I've kind of labeled and included the most important of the anatomy structures in the respiratory system. So we start with the air passages. That includes the sinuses, the nasal passage, the throat passage, the trachea, the bronchial tubes, which go down into the lungs. And then we're looking at the lobes of the lung. We're looking at the covering of the lung, or the pleural covering, the alveoli, or the actual air sacs, which is where the gas exchange takes place during inhalation and exhalation. The muscles of breathing encase all of those systems and serve to regulate the breathing mechanism, and also give us that voluntary and involuntary mechanism of breathing. Pulmonary vessels and arteries carry the gas exchange, take out the gas, bring in the airflow, and that entire system, the respiratory system, is regulated and happens in the brainstem. Now we're going to move on to the vibrating source, which is the laryngeal system. That was the green circle that was circled in the throat area. And again, this isn't every structure, but for our purposes today, these are the ones that are most important for the discussion. So sitting on top of the airway in a very protective position is the epiglottis that closes over the vocal folds when you swallow to protect the airway. Immediately under that is the pair of vocal folds, a vocal fold on the right side, a vocal fold on the left side, and this is the vibrating source of the laryngeal system that makes sound. It's not just a coming together of those vocal folds, it's kind of an undulating process. As the air from the respiratory system moves through the vocal folds, there's a sucking together and a releasing. It's called the Bernoulli effect. That's how physicists refer to it. And there's a very aerodynamic process that happens there in the vibration. The vocal folds vibrate from the bottom up, so it's not open, they open and close, but they also have a vibratory capacity, which is what produces voice. There are cartilages in the vocal, behind the vocal folds. There's two of them. They're called the arytenoid cartilages, and those regulate the movement of the vocal folds, also one on the right side and the left side. And then the structure itself, the voice box or the larynx, is also made of cartilage. All of the tissues in that area in the upper airway are covered with a mucosa, and that's very important for the health and the function of voice. So those are the components of the vibrating source, or the laryngeal system, which comprise voice. Then the modifying source was the last piece on that slide that had the circle around the nose and the mouth, and those are the resonating cavities, which include the nose, the pharynx or the throat, the back of the tongue, the oral cavity, and then the articulators change the shape of the sound as you make speech sounds. So just as a little experiment, if you say the sounds pa, ta, ka, and you say it rather quickly and connect those sounds, pa, ta, ka, what you will feel and experience, you can do that right now during the presentation, is you'll feel movement of your tongue, you will feel movement of your teeth, your lips, your jaw. Those are the articulators. They shape the sound. So if you make that sound, pataka, what you'll feel is all those movement and the regulatory movements of the lips, the tongue, the teeth, the jaw, and the palate working together to shape and to make the sound. Okay. That all goes back to the brain, which, as we started with, regulates all of the signals, sends the signals process through the brain. So what happens is, if you look at the bottom left corner of this slide, I say something, I hear it, and then on the brain slide, I had the words in red that said awareness and adjustment. That's where we process what we've said, and then we modify it as we need to. So the example I like to use is if I'm singing in a choir and I've got a 20-person choir around me. We kind of miss those days lately, don't we? Being able to sing together in a room or sing worship at church. So let's say we're singing in a choir and I'm trying to blend my voice with the person who's sitting or standing next to me. And I hear them and they sound a little bit different than I do. This is where the feedback loop comes in and I make adjustments, right? I might make adjustments to my volume. I might make adjustments to my pitch, but I'm trying to blend. And that whole phenomena of changing the way that our voice sounds and feels has to do with how we hear it. And this is where many people who come in for voice and speech therapy, we ask the question, does the voice or does the speech sound different to you or does it feel different? And 9 times out of 10, I get the answer, both. It sounds different and it feels different. And that's because the person has that encoded pattern of muscle memory, of auditory perception, what the voice sounded like and felt like before they had any challenges with it. And now they can tell it doesn't sound the same, it doesn't feel the same. And so that's what leads people in for therapy. Let's talk about some of those reasons why folks come in for therapy. So common communication problems in Parkinson's disease and what those communication problems are based on. The foundation for that is similar to the other symptoms that you'll find with Parkinson's disease, and that is a movement reduction in the muscles that control voice and speech. So the systems that we just talked about, if we look at those 3 individual systems, the respiratory system, which drives the voice and speech, then also the sound source or the vibratory capacity, the voice mechanism, the laryngeal system, and then lastly, the resonating and the articulatory modification, that's where there can be movement reduction in the muscles that control, and certainly there can be problems at any one of those levels. The most common ones that we see are symptoms that can include voice tremor or a variation of the pitch and loudness, especially noticeable on a sustained sound such as ah. There can be reduced volume or hoarse and breathy voice, certainly some slurred speech or what we call imprecise articulation, because of some difficulty in controlling those muscles that work that third component for the specific speech sounds to be made and understood, which leads to difficulty being understood by others. And then the last thing that most people aren't as aware of is sometimes there's difficulty or trouble expressing emotion through voice. So somewhat of a change in the intonation or what we call inflection pattern of voice, where there might seem to be less expression. And we actually can work on that in therapy as well. If we look at overlap of some co-occurring diagnoses, frequently we'll see the pattern of communication challenges that I just shared with you in Parkinson's disease. And then there is some overlap. My good friend Christina DeStolfo-Romack has done some research work on this. And what we'll find is some hypomobility. And that means a little slowing of the movement of one or both of the vocal folds. So it means there's a little bit of a reduction in the vibratory capacity of the vocal folds, which is noticeable in the voice. And then also as we age and have more birthdays, naturally what happens in a high percentage of the population is we see atrophy of the vocal folds. And that can mean that the tone or the bulk of the vocal fold itself has reduced a bit. So I like to compare that to ladies. We all know that that skin that hangs under our arm, it's not as taut or it's not as tight as it once was when we were younger and in better shape. And what happens to the vocal folds is they tend to lose some elasticity, some tone, and some bulk, similar to that muscle system. So those things can be occurring with the symptoms of Parkinson's disease. We certainly see those aside from, or we can have Parkinson's disease symptoms of speech and communication without hypomobility or atrophy. Just bringing that up because sometimes there's some overlap there. And then I want to go back to vocal tremor or essential vocal tremor, which can also occur in the absence of Parkinson's, but because it's a movement disorder, we put it with that because we sometimes see it. And that's, as I said, the rhythmic modulation of pitch and loudness because of some shaking or tremor movements in the vocal tract. And I'll show you in a minute where those can occur. On the right-hand side, I'll go through the different areas where we can see that. And on the left-hand side, you'll see an actual photograph of vocal folds. So that is a picture of the vocal folds. It's sideways. Normally when we look through a nasendoscope or a stroboscopy exam, we'll see them they'll be turned, a quarter turn facing up. But for the purpose of this slide, they are sideways. And then you can see the sound waves coming out to represent that involuntary shaking. And that can happen at the palate. So I put an arrow at the palate level. You can have some shaking there. Also at the base of tongue, we can have tremor or shaking there. And then the third place could be the posterior pharyngeal wall. So the back wall of the throat area can also have some tremor. And then anywhere above the level of the vocal folds, we clinically refer to that as the supraglottis or the supraglottic area. And then of course the vocal folds themselves can have tremor, or you can have involuntary movement. That last area that I highlighted is the larynx itself. So there can be some tremor there as well. Those are the primary areas where we see vocal tremor. Common Parkinson physiology, as we talked about, we can describe that as low oomph. So kind of a de-energized system. And the goal of any therapy should always be to energize or to adapt the system so that you can have maximum voice and speech production. As we said in the first set of slides on anatomy, that can happen because of respiratory deficits, laryngeal movement issues. And what we know is true is about 89% of patients with Parkinson's disease will have some type of voice challenge or a laryngeal manifestation of the disease, which may look like the symptoms that we talked about previously. It could be breathiness, roughness, hoarseness, or a bit of tremor in the voice. So if we look at actual incidence, what we see on this graph is a climb in the percentage of patients who are reporting voice problems across the disease span. If you look at 6 years after diagnosis, it's right around that 50% mark. And then as the disease progresses, really close to 86, between 86 and 89% of people report some issues with their voice as they've had the disease longer and they're seeing and becoming more symptomatic. So slowly progressing over time, and early symptoms are definitely mild. But let's think back to that initial slide that I showed you, that even though neurological problems can cause speech and voice and communication challenges, treatment is always best early on because it's easier to adapt the system at that point than to wait until, as this graph shows, you're experiencing more difficulty and the severity has increased as things have progressed over time. Really important to remember though, and I can't emphasize this enough, that even though there's a neurological diagnosis and Parkinson's disease has been discovered, or you or your loved one are symptomatic for that, that is not your vocal identity. Your vocal identity is a very important part of who you are. And it's really as unique as your fingerprint. It really is. And I like to see each individual person based on what their communication needs are, what their strengths are, what their weaknesses are, look at their personality and get to know them and see what they're using their voice for. There's a lot of variability within these challenges and within this disorder. And it's definitely true that because everyone is different, the symptoms impact folks differently. So if you love to speak or sing, if you're a lawyer who has a lot of appointments that are on the phone, and these days we're doing so many things virtually that we're using our voice with a little bit more intensity than what we're used to, if you will, or you're a singer in a choir or in a community group, then you may notice voice problems or speech problems earlier in your diagnosis than someone who doesn't use their voice that much or use their voice professionally. A couple slides I have here just showing teaching, preaching, worship leading, using your voice in a choir. Those are high vocal demand kinds of hobbies, if you will, or careers. And so that matters when you go for treatment, what those vocal demands are in your life and how the person treating you can best meet you for those demands. Let's talk a little bit about common complaints that we see in the clinic with folks who have been diagnosed with Parkinson's or are right at the start of that journey. These are actual quotes that patients have said to me or to my coworkers. And the first one is, I feel like my speech is not precise. Another word that I hear frequently is muffled. Someone will come in and say, I feel like my speech or my voice is muffled. And initially, they may even think that that's a hearing problem when it's really a speech and voice production issue. My voice trails off before I finish my thought. Now, this is pretty common actually in Western Pennsylvania. We kind of have an accent where we let our speech, or sometimes we let the phrase or the sentence drop off at the end, which is what I'm demonstrating right now. But when you're thinking about how you're using your voice and you're listening to yourself, that can be an issue of that little Western Pennsylvania accent kicking in. It can also be an issue of not having enough breath support or respiratory drive. And so just saying too many words without stopping to take a breath. I think we all get caught in that pattern when we're being enthusiastic or when we're trying to give a lot of information in a short amount of time. I hear that complaint with my teachers frequently. The third complaint is my voice quality is inconsistent. So some folks feel like at some point in their disease process, they're not sure when they open their mouth what their voice will sound like. And that can be really, really difficult and really strenuous and stressful in social situations especially. Also, I have difficulty being heard over background noise. Again, that can be that low oomph or reduced respiratory drive that causes less volume in the voice. And so we definitely work on loudness as a skill. And it's really more than just shouting or having more volume. There are ways to do that in therapy where the technique actually protects the voice so you're not straining. Everything that we do, we try to impart good techniques so we're preserving the vocal mechanism without strain. And that goes with the last one there. I can no longer use a loud voice as well. Couple more common patient complaints that I hear. My voice is tired and increasingly hoarse at the end of the day. Now that happens proportionate to how much the voice is used. I was working with a gentleman the other day who's kind of shy and not really social during the day very much, but he also gives training webinars for construction workers for safety. And so he wanted to make sure that his voice was in tip-top condition whenever he went. And a lot of times, as I said previously, this isn't so much recognized by the patient, but it might be recognized by the people around. And I know it's hard, but feedback that comes from family members is very important. So if you have a spouse, a grandchild, a son or daughter who's telling you, you know, I'm not sure what you mean, I'm not understanding your speech, or your voice is sounding more consistently hoarse, those are good checks to get an exam and to see someone about voice and speech therapy. The last two, my singing range is reduced. I have trouble reaching the high notes. Pretty common as we all normally age, and sometimes a percentage of the population will have that vocal atrophy, and that can be a symptom of vocal atrophy or hypomobility, poor movement of the vocal folds as well. And then I have to frequently clear my throat. A common complaint, not only for Parkinson's patients, but for folks who use their voice quite frequently and are not well hydrated. So there are other systems in play there that we will take a look at when we talk about vocal hygiene, and certainly with a good therapy program, that would be addressed. All right, so let's talk about evaluation and treatment. if you go to have an assessment for your voice and speech, there are around 4 or 5 components of that that you can pretty much count on being a part of the program. The first is a thorough case history. Anyone who's evaluating you should be asking you about your medication, about the history of your diagnosis with Parkinson's, if you're currently under the care of a neurologist, which would definitely be the case, I think, for most folks that have Parkinson's, unless they're just starting their journey and they're just getting appointments with different specialists. And then most of the time, we would want a laryngeal exam. So we would want someone to do either a nasendoscope, where they pass a thin fiber optic scope through the nasal passage. It hovers just above the airway at the level of the vocal folds, and it's dynamic, so you can speak, you can sing, you can swallow, and we can see the vocal folds in action. We can also see if there's any kind of a gap when you close your vocal folds and they come together to swallow. That's where part of the case history that's very important is also asking about swallowing problems, or if you're having any swallowing difficulties, that's something that we would want to also address in therapy and get you some clinical help for that. And then analysis of voice and speech. Sometimes this would be done through electronic measures. More often than not these days, we're doing that without our fancy equipment because of COVID and trying to keep things clean and sanitary. It can be an audio perceptual analysis where the therapist or the clinician asks you to read a number of sentences. There might be a decibel meter there to actually measure your volume and take some data on that, and then do an analysis and see how that falls into categories against norms and whether or not you might benefit from therapy. The big component of that in deciding whether or not someone benefits from therapy is what we call stimulability testing. It's really important during an initial evaluation to see how you or your loved one will respond to therapeutic techniques. And if it's not a good response, then we might modify a program or ask you to wait until maybe medications are in place. If someone's about to go in for surgery to have a deep brain stimulator implanted, we might wait until after that. We would certainly do a baseline evaluation before that implant and then go back and measure speech and voice again. And then lastly, there would be a treatment plan executed, which would include specific goals. Again, that should be highly specific to you and what your needs are for communication and for speech and voice. You may have only voice complaints and no speech complaints. And so the clinician or I myself would modify that treatment plan according to what your needs are. This is a picture of a laryngeal exam where the nasendoscope is actually being passed through the nasal passage with that light on the end, and then the physician or the speech language pathologist can view the vocal folds on a screen, and most of the time you can look at that at the same time, and you can see that process of speaking, breathing, swallowing, maybe some singing, and the person would ask you to do some specific tasks and then make an analysis of the function of the larynx and how the vocal folds are moving together and apart and what that area looks like during dynamic speech and voice use. The treatment plan then is definitely established with the patient. And the first part of any good voice treatment plan would include a vocal health plan. As I talked about before, that has to do with the hydration of the vocal folds. I'll go through a couple quick pieces of that. And then definitely the treatment plan would reflect the therapy or the type of therapy to address individual communication needs. There should be a home practice program implemented. Most people know who have experience with Parkinson's disease themselves or with their family members that home practice is super, super important. You not only want to be in a position where you're doing therapeutic work in the clinic with the therapist, but you're also doing that at home, because the ultimate goal is to carry that over into your speaking, your voice, your speech patterns, and your vocal technique so that you make improvement and you can make those adjustments appropriately. And then a reevaluation is always in good order to measure progress throughout, especially at the end and discharge of therapy. And then I like to say that once you're under my care, you're never really going to hang out alone with your therapy for your voice and your speech. You're always going to have me as a consultation provider when needed, with other professionals, with yourself, with your family. And group therapy is very important. The Speak Out program that I will talk about in a minute is a big proponent for that. And we find that communicating in a group is more like real life. And so group therapy can be a very important part of the treatment plan. So let's just go over some quick vocal hygiene principles. And this is another great takeaway point from today, that you can leave here with some things that you can implement right away to care for your voice. So the first one, again, is looking at that very first system that works under the direction and the piloting of the brain, if you will, the lungs and the respiratory system. So of course, avoiding exposure to smoke-filled air or pollutants, irritants. A lot of us are using Lysol and a lot of really strong cleaners these days in our homes to make sure that we can keep COVID out of our homes. So what you want to do is mask up. Again, I know you have to mask up whenever you're going out, but it's a good idea to mask up so you're not breathing those irritants in. They can definitely trigger a cough and cause some irritation in the throat, and definitely irritation in the lungs as well. The second point on here is to treat any conditions that affect your lungs, such as asthma, if you have COPD, anything that you need to be under the care of a pulmonologist for. If you use an inhaler or a nebulizer, you need to make sure that that you understand with that professional, that pulmonologist, that allergist, or that asthma specialist, how often you should be using your treatments, and then keeping consistent with it. And then exercise, right? Such a great thing to keep our lungs in good shape and in good health. Looking at dehydration very briefly. Dehydration is important with the vocal system, the laryngeal system, the area in the oral cavity. All of those tissues are covered with a very thin mucosa. And when you're dehydrated, you know, it's said, and this is definitely true clinically, that you don't necessarily feel thirsty until you're already dehydrated. So it's a good idea to drink water unless you're on a medication that contraindicates that and your physician has told you that you should not be overhydrated. It's a good idea to drink a couple bottles of water a day if you can manage that. There's tons of flavored options nowadays, which are good, and lots of people appreciate those. What happens when you're dry is that your brain literally sends a signal to produce mucus, because mucus is that slippery, slimy coating that keeps the systems moist and that keeps that covering of the oral cavity inside your mouth, inside your cheeks, inside your nose, going down your throat, the esophagus that goes down into your stomach. It keeps all of those tissues moist. And so if they're not moist from your own hydration, systemic and surface hydration, then you will produce more mucus. And the mucus that your body produces is pretty sticky and thick. And sometimes when we do a nasendoscope or a stroboscopy on a patient, we can see that thick mucus sticking on their vocal folds. Caffeine, alcohol, antihistamines, those are all things that we use or come in contact with frequently. They are drying. And so you want to make sure that if you're someone that has 2 cups of coffee in the morning, that you're balancing that out with 2 more cups of water pretty shortly after that. And then of course our environment has to do with how dry we are. Dry air, air on airplanes, heat in the winter, air conditioning in the summer, just breathing through your mouth can be drying. So pay attention to those things, and if you can modify your environment to maximize that environmental hydration and the humidity in the air is a great thing. Looking at the next slide, a couple bottles of water. That shows my slide for systemic hydration, which is super important to make sure that you're drinking enough clear liquids and water and things that aren't caffeinated. And then what you'll see beside that is a personal steam inhaler. And these are sold over the counter at most pharmacies. I know around Pittsburgh, they have them at CVS and Rite Aid. This provides a steam treatment, which you inhale through your nose and your mouth, and it puts surface hydration directly on the airway. and that mucosa covering in the throat and on top of the vocal folds, which is really, really nice to supplement what you're drinking, especially in the winter whenever we're using dry heat. The only word of caution I would give you about this, it's very easy to use. You just add the water to a reservoir inside. It boils the water and then it produces a nice steam treatment, lasts about 11 to 12 minutes when it's plugged in. It is an electric unit, so you want to be very careful with the hot water that you don't tip it over. It also comes with a small inhalant pad that has menthol and eucalyptus on it, and it's better not to use the inhalant pad. We tell our patients to throw that away because menthol can be drying. So if you're a person that sucks on a lot of cough drops, you might want to reconsider that and use hard candy or something without menthol. The next slide shows another piece that is not vocal hygiene, but now we're moving into actual treatment and therapy techniques. This device is called the Expiratory Muscle Strength Trainer, or the EMST, and this can be purchased online, and it looks almost like and is about as big as an inhaler, like an asthma inhaler. And the idea is that this is spring-loaded. And so when you twist the end to certain settings, you make it tighter, and then it provides resistance, which you blow into and blow against the resistance. So under the guidance of a therapist, I would set you up with a program in this if you felt like you had shortness of breath while you're speaking, you felt like you were running out of air when you're talking. This would be something that we could use to train and strengthen that respiratory system. Another component of therapy is to look at the emphasis, or where the vibrating source is, or where the sensation, rather, I want to say, of the vibrations are for speech and voice, and also where there might be strain and tension. So as I said previously, if we're increasing the volume of speech and voice, what we don't want to do is put a lot of tension on the throat area, because that can cause trouble with the vocal folds, with the throat area itself. So we want to actually refocus speech so that it's more in the mouth and in the lips. And that's another speech therapy technique which can be unpacked and actually works very well in conversation, and also as a supplement to some of the things that are more specific for Parkinson's. Speech precision, we talked about the articulatory movements of the tongue, the teeth, the lips, the jaw. This is something else that I like to highlight in my therapy sessions, because we don't want to just look at the hoarseness and adjust the volume of the voice. We want the speech to be precise and clear. And that's another focus that we look at during therapy. So basic approaches for Parkinson's, kind of what's out there, right? Let's talk a little bit about the therapy programs. Really right now, there's two. If you look at the left side of the slide, you'll see there's LSVT, which is the Lee Silverman Voice Therapy Program. It's a great program. It's been around for years. And then the newer program, which is what I'm certified in, and a lot of people in the area, well, at least 2 or 3, not a lot, I should say, is the Speak Out program. And I'm going to give you some more specifics on that in a minute. There are devices that can be used. I just showed you the second one on the list on the right-hand side, the Expiratory Muscle Strength Training System, known as the EMST. Portable amplifiers can also be used, which are worn around the neck and amplify your voice. We have teachers that use portable amplifiers when they talk. Different pastors may use those, folks that give lectures, professors. And then the Speech Vive is a somewhat older device as well, which induces kind of an ambient background noise into your ear when you speak, and that sends the signal to your brain to increase loudness and clarity. And so it works by wearing the device, utilizing it during conversation or communication, and that's what it looks like. It almost looks like a hearing aid or a hearing piece. That's the EMST that I showed you, and that's a picture of a portable amplifier. So the common goals of most of these basic approaches for Parkinson's are providing the patient with some awareness to adjust their voice. As I said before, respiratory drive is a very big component, and so we want to make sure that that respiratory drive is intact or is adapted to the maximum amount that it can be. And then the amplitude for phonation will be louder articulatory precision. And then the last area, and we never ever want to exclude this, is cognitive linguistic skills. So any good Parkinson's therapy program should also include how you process language, a little bit of memory work. Transitioning thought into language is an important component of that well, which is called cognitive linguistic skill. So the founder of the Speak Out Therapy program is Samantha Ellenderry, and it's out of Richardson, Texas. And she actually started this program in her living room. And then the home office, so to speak, where this originated and the research behind it came from the Parkinson Voice Project. And we call this program Speak Out Therapy. The tagline is Live with Intent, and certainly the crucial aspect of Speak Out Therapy is to speak with intent. And intent has many different words and multiple meanings, but a few of them that my patients have come up with is that intent means that you're loud. It means that you're speaking with a drive and with strength. It means that you're focused on the meaning of what you're saying, not just speaking. You're determined about your communication message. That's another word that is synonymous with intent. Your communication is purposeful when you're intentional. It's bold. It's strong. So instead of having a weak, kind of muffled, as I said before, voice and speech, the goal of Speak Out Therapy and speaking with intent is to have a strong voice and strong, clear speech. It is focused. We are very intentional or focused on what we are saying. There's oomph behind it. Remember the slide that said low oomph? We're trying to regain that oomph, call back that territory. And it's confident. If we are sufficiently loud and we have the volume and the meaning behind our speech and communication, then we will embody that confidence as a confident communicator. It's energized, so it has that oomph or energy behind it. It is deliberate. I like to think deliberate and determined kind of go together, and it's expressive. So instead of holding back and not having that intonation or that expression behind the voice and the communication, we're looking to advance that expression. So principles behind Speak Out Therapy, there are 4 main principles. The first one is that, as we know when we talked about the anatomy and the physiology of voice and speech, that speech and voice are motor sequencing tasks. And there are 2 motor systems through which the signals are sent. Nerves that signal and coordinate movement require dopamine as a neurotransmitter, and as you know, that's the effect of Parkinson's, is the reduction of the dopamine. One motor system, however, is more affected by the reduced dopamine than the other. Let me read number 4 again, because that's a very important, if not the most important parameter of Speak Out Therapy. One motor system is more affected by reduced dopamine than the other. So let's talk about what that is. If we look at the neuromotor control of speech and voice, there's the extrapyramidal system that is on the left column of the slide. That's where we see automatic movement. Maybe I could give the example of an automatic swallow when you're drinking or eating. You're not thinking about it much, it's just happening. So there's no effort. If someone asks you a question and you answer, there's a certain automaticity to that answer. Those signals are the ones that are disrupted because of reduced dopamine. I use the example of a swallow. Now, if we talk about the pyramidal system, that has to do with purposeful, or here's that word again, intentional movement. It requires more effort because you're thinking about it and you're engaging the system purposefully and intentionally. There is less or no disruption due to the reduced dopamine in the system. And the example of that is the difference between an automatic swallow when you're drinking or eating, or an intentional swallow when you swallow hard. And I'm going to give you another example of that. If we do a little bit of a demo here within our group, I'm going to ask you all, wherever you're seated, just to say your name. So if I just say my name, I would say Tracy Thomas. Now, if I asked you to say your name as if I'm on the phone with you And I'm asking for your ID because you just won the biggest prize that Publishers Clearinghouse ever gave. So now you're going to win $1 million, and I'm saying, I need your name for identification. You would say it with certainty, with boldness, with conviction, and with a certain intentionality that you might not have said it the first time when it was automatic. So now if I say, I'm calling from Publishers Clearinghouse, could you say your name? Say it now. And I would say, my name is Tracy Thomas, with a lot of intention and deliberation because I want that check from Publishers Clearinghouse. Let's do another example. So if I were to be asked by my husband or my family what I would like for dinner, or if I were to ask them what they might want for dinner, I might say, George, what would you like for dinner tonight? And there's nothing too exciting or expressive about how I'm saying that. That kind of falls more into the automatic response category. Now, if a famous person, someone I really, really admire, was coming to my house for dinner and I was trying to plan with them and I was on a Zoom call, I wouldn't say that in that kind of held back, less intentional way. I would say it with a lot of enthusiasm and a lot of strength, like I'm the expert cook. And I would say, let's take an example of who's a famous person that I might want to have dinner with. Well, I would say my dad. So I would say, Dad, what would you like me to fix for dinner? Right? And it becomes more intentional. It's clear, there's a certain clarity to the speech because I'm embodying that intentional tract or the pyramidal tract versus the extra pyramidal tract, which is the automatic system. Now let's give that swallow a go. And if you just swallow any saliva that's in your mouth as you're sitting here, it's more intentional because I've asked you to do it. But now if I tell you to produce a hard swallow that is even more intentional, it's going to feel kind of like a gulp, and you're going to engage more muscles, or you're going to tune into those muscles a little bit more. Let's do that all together. And you should have felt that like a hard swallow, like a little bit more of a gulp, or that intentional, utilizing the motor movements that your brain is organizing and putting that purpose behind. All right, so following a medical voice evaluation that we've already talked about, what does Speak Out therapy look like? So the initial session is an evaluation and a voice recording, and then there are 12 individual therapy sessions that take place one-on-one with a therapist. And then we have group therapy for skill maintenance, which meets once a week, and that group is called the Loud Crowd. There is homework every day, twice a day, and that's 25 lessons that happen during those 12 individual therapy sessions. That's the take-home work for Speak Out. In the words of my good friend, Mr. Smith, who is part of my Speak Out group, when asked what is Speak Out therapy, he said, it's small steps to make an overall big difference. And I really can't think of a better way to explain that myself. Everything that we do in therapy and in the clinic, it looks like small steps, but those small steps make a big difference in the end, and definitely make a big difference functionally in how you view, how you understand, and how you use your voice and speech for communication. So I want to go back to those initial 2 points that I made. Neurological changes can cause speech and voice changes for sure, but early intervention is always best. And in conclusion, I would like to make 4 points that you can take home from here. The first one is that your voice requires active measures to stay healthy, and that's true for all of us. Healthy voice habits are like healthy dental habits. It becomes a part of your daily life to do those checks, to make sure that you're hydrated, to make sure that you're not breathing in irritants, to take care of your lungs. All of that is part of a healthy vocal hygiene program. Persistent or recurrent hoarseness should definitely be evaluated by a laryngologist. That goes without saying because a picture is worth 1,000 words, and we always want to take a look and make sure that the vocal folds are healthy and that the tissues are healthy and intact before we start a therapy program, especially as it relates to swallowing. Any targeted treatments for voice, speech, and swallowing can help to maintain functional skills, especially if you're seeing someone who's specialized in Parkinson's disease. And as I said before, the biggest take home is early intervention is best. So with that, I will conclude. And thank you so much for this opportunity and this time. I have time to take questions. If anyone has questions.
Thank you, Tracy. It looks like Beth Ann may have a question.
Okay, can you read that one for me, Casey?
Sure, I think actually she'd like to ask it herself.
Okay, sure.
Thank you. When I first moved here, I lived in Colorado, where the elevation was a mile high. At that point, I was truly struggling with my voice. It was getting stuck. I was getting terrible problems with dyskinesia in my throat. Now I've moved to Indiana, Pennsylvania, where we're only 1,000 miles high. Not only has my speech improved, but my singing voice has improved. And what you mentioned before about your identity being reflected in your voice,
yes.
It was really painful to lose my singing voice. I had sung with a quartet prior to this and had gone from that to being a song leader. But it's coming back a little bit. I just wanted to let people know that my neurologist said that states like Colorado are the worst place in the world for people with Parkinson's because of the voice problems, because of the oxygen, that you're not getting enough oxygen. When we started with the masks, it became nearly impossible for me to breathe. Even my pulse was low. Everything was affecting mobility. Here, I feel like I'm a different person. And I also am taking a Mantidine for the dyskinesia, which really helped tremendously.
Yeah, that's fantastic.
I wanted to share that. Thank you.
Thank you, Beth Ann. I believe Donna has a question.
Yeah, I had a question about DBS, but I'd just like to comment on Beth Ann's comment because I lived in Colorado too, but I'm a caregiver for Vicki Herbert that has Parkinson's. But it is also, besides low oxygen, it is very, very dry. So just moving to Pittsburgh, you increased your humidity by quite a bit. That affects your voice.
Yeah, you know, on the flip side of that too, folks, some people find that living in Western Pennsylvania, because of the higher humidity, we tend to have more allergy issues. So while you live in those higher altitude places, the air is drier, you can also have more allergies in Western Pennsylvania. And so it's important, if you have postnasal drip or any kind of excessive mucus production, to look at that from an allergy perspective as well.
But I had a question on DBS. And my sister has DBS, and she also takes amantadine, which I found interesting when I was chatting with Beth Ann. But DBS seems to have affected her voice, and she goes to a Mickey Mouse voice, especially after she eats. It's a high squeaky voice. And it just happens a lot after she finishes eating, and then it takes a while for her to get her voice back. But then
so the question I would have on that is, how long has she had the DBS, and did she have a voice and speech evaluation prior? Because what we do know about DBS is that it can affect voice and speech. It's really important to get a baseline measurement going into that, or pre-surgery, and then had to be followed by a speech language pathologist so they can note any changes and they can address those.
Can you address them with DBS settings?
That's a great question. From my experience and the patients that I've worked with DBS, you know, there's always that initial time where they're trying to get the settings, and you're kind of back and forth from the clinic. And in the experience that I've had, some of the motor movements definitely can improve as the settings are more perfected and made more appropriate. But I would say if there's a voice pitch change, she would be a person that, you know, maybe could be worked with in a voice clinic or a voice specialty practice. And definitely that relationship to time of day and eating is a concern, based on swallowing as well. I mean, I would bundle that whole thing together with the upper airway, and I would want someone to see her.
Just as an aside, she has DBS for 10 years, a very long time.
She's had for 10 years. So then she's not in that place where they're doing the initial adjustment.
No, but There's adjustments for certain movements in her legs that they do specifically, like on the parameters that they could change. I just wondered if anybody has experience with changing the parameters that we have available with DBS to affect the voice.
I don't think it's commonly done just to adjust the voice. Someone said they have. Okay.
Yes,
What's your experience in that?
This is Beth Ann. I had DBS, and whenever I have any type of a what do you call it? No, not a CAT scan, but starts with an M.
MRI.
An MRI. When I did an MRI, they have to adjust the settings, and I noticed that when they adjusted them, my speech improved, but other things got worse. And when you try to adjust and play with your settings, you're going to affect something else.
Yeah, that's why I said in my experience, I don't think they would adjust it just for voice, but you know, everyone has a hierarchy of symptom presentation, and so the physician who does that adjustment would take into consideration what the complaints are at that time, and also the medication levels, because you're trying to lower medication when you're using the DBS. The whole purpose of the deep brain stimulator is so that you can get off some of the movement meds, but sometimes they'll augment with those meds as well. So I think it's really important to have a look by a neurologist with that.
Just as an aside, she had DBS with Activa, Medtronic's Activa, and it was a constant voltage control. And when she had her battery replaced, she went to a Percept by Medtronics that goes with constant current, but her speech has improved. Her other movement got worse, but her speech has improved.
But the speech has improved. Yeah, isn't that something?
Yes. Well, thank you. We have a few other questions. Thank you all. Do you need a prescription for this therapy, and is the cost covered by insurance?
That is a great question. So to come and see me, no, you do not need a prescription. And the way that I run my clinic is I do a phone consult first. And so anyone that would want to reach out to me, I can, in fact, I had a slide, I must have not put it up, that has my information on it. I'll give you guys that now. And I would talk to you on the phone for about 15, 20 minutes, try to take some information, see if you know, the person that you're concerned about or yourself is a good fit for therapy, and then bring you in and do the speak out evaluation. I do take Medicare. It is the primary red, white, and blue Medicare of Pennsylvania that I take. And that does cover the speak out therapy. And then the group is a community group that has just a nominal dues, but nothing that's like a copay or anything like that, just to cover expenses.
Okay, thank
So
you.
let me give you, before I forget, so my phone number, I did have a slide with that on. It's, my contact is 412-580-8300. My office is in Seven Fields, Pennsylvania, which is right off the Cranberry Mars exit, if you're familiar with the Pittsburgh suburbs. And then my email is Tracy, Tracey, at Advanced Voice, and there's no D on that. It's not Advanced Voice. It's just Advanced, ADVANCE, AdvancedVoicePA.com.
I just sent it to everyone in the chat box.
Yay! Yes, there it is.
Okay, thank you. We have another question. Is the exam via the nose helpful revealing or regarding swallowing difficulties?
It is, yes, it is. And very frequently what a laryngologist will do, who's specially trained to view the larynx, the vocal folds, the top of the airway, is they'll take a look, they'll have you do some dynamic things like breath holding, swallowing, and you can see if there's a gap during the swallowing that there might be a danger of food going down the wrong way or being aspirated, which can be a problem, especially in later stage disease, Parkinson's. And so they may recommend an actual swallowing evaluation, we have a great swallowing clinic here in Pittsburgh that's out of Ioneer Institute. It's called the Swallowing Center. And so that would require a script from a laryngologist or a speech pathologist to say the recommendation is to go to the Swallowing Center and have a swallowing evaluation if we needed to follow up. And then there's also swallowing therapy and techniques that can be implemented from that. So it's always better to take a look if you're not sure.
Thank you. Okay, I think, Beth Ann, do you have another question?
Well, I kind of wanted to let you all know that there is a book written by John Argue. It is called Parkinson's Movement and Communication. And he's been studying this for many, many years. And there's a chapter, and chapter 2 is totally about communication. And I found it very helpful in organizing my class called Sing for Parkinson, to Beat Parkinson's Disease. Now, I did want to announce that the classes at the Y have not had attendance because of COVID. So therefore, we're going to put the Move and Groove class online. So I will share that information with you shortly so everybody will get to see it. We're doing a movement lab type thing that Pamela Quinn does in New York, as well as a Dance for Parkinson's too. So we start in the chair and we get up and go to the ballet bar and we do some movement. So I will let everybody know when that's going to be online. We're getting real close to getting ready to tape it.
Okay, thanks, Beth Ann. And we have time for one more question.
We typed ours in. So.
Oh, okay. Let me look.
About the loud crowd.
Oh, sure. Let me find that. Actually, go ahead. I don't see it at the moment. Oh, here it is. Okay, go ahead, Laurel.
Is someone permitted to join the loud crowd if they completed an LSVT? It was kind of a partial speak out program up at Health South, which is now Envision, I think it is, approximately a year and a half ago.
So yeah, I don't like using words like allowed to. The way that Speak Out, the group in Richardson, Texas, runs the program is under the ideal circumstance. And the preference is that someone has received Speak Out therapy through a certified Speak Out trainer, which would be someone like myself, and that they've completed that course very recently. The reason is because a year or more, I would even say 3 to 6 months, because we can see rapid changes, that would leave a gap that would be too big. So we would want to have done the 12 Speak Out therapy sessions and then immediately go right into the loud crowd. It's not that it's not allowable or it's not the best ideal situation, but it doesn't serve the patient well to come into loud crowd if they don't have recent Speak Out training, because the techniques that are used and that are encouraged in loud crowd are from the Speak Out program. Does that make sense?
Yes. Would Medicare pay for that a second time?
So the answer to that is, when you say a modified LSVT, so there's not really a blending of LSVT and Speak Out. I don't know of anyone that does both of those. So if the provider was certified as a Speak Out therapist, then they would have been doing Speak Out therapy. If they were certified as LSVT, they would have been doing LSVT therapy. So do you know how many sessions that was?
Oh, he went at least, I think, twice a week or more now. I forget the 12, but it was an LSVT loud.
Yeah, that's not Speak Out.
Incorporated the Speak Out into it. And then the therapist at the conclusion said there was a loud crowd group that he could possibly join, but we never heard any more about it.
Yeah, I would want to do another evaluation and possibly Speak Out therapy. And to answer your question, as far as my knowledge goes, Medicare would pay for that unless there's a cap on the number of speech therapy visits. And you would have to call the number on the back of your Medicare card to ask about that. But as a provider, I do take Medicare. And that shouldn't be a problem. So if you wanted to find out about that, and then call me and we can talk about setting something up. My group right now has 6 people in it. They're all extremely intelligent, very delightful people. And they've all been through the Speak Out program.
Okay, thank you.
Yeah, sure. We'd love to have him join based on what you can find out from that. But give me a call. We can talk about it.
Thank you. It looks like there's John Dean had provided some really informative information in the chat. So I encourage all of you to check out that link.
And I'm good for time, Casey. I could take one more.
It looks like
I can take one more question.
Okay. It looks like there is another question.
Okay.
With dehydration, I hear conflicting advice. 1, drink when you're thirsty, versus 2, as you said, and I agree, that's too late.
Right. So you've got to look at the medication regimen as well. Because the question being, is there some contraindication? So some people say that maybe someone has congestive heart failure and they're on a diuretic. So you want to be very sure with your physician that there are no contraindicated medications or treatments going on. And then it is not best to wait until you're thirsty. It's best to kind of plan to hydrate during the day. So I like these smaller bottles of water personally because they're not as overwhelming to me as chugging a big 16-ounce bottle or carrying a water bottle around. And there's all kind of tricks that you can use to do that, but just setting some around the house, some smaller water bottles, and drinking those, not necessarily at a prescriptive time, but definitely throughout the day. I think that is better, generally speaking, than waiting until you're thirsty.
Thank you.
And that is the gold standard in the industry, by the way, as far as clinical advice goes from the medical field.
Okay. Well, it looks like, okay. Tracy, thank you so much. Any parting thoughts, comments?
I'm thrilled to have been able to do this, to provide some information for you all. I'm thrilled at the number of people that came and attended this webinar. It's a great honor. And like I said, I don't ever claim to be the expert. As Michael J. Fox said, I don't have the disease. I feel like you guys are the experts and we learn from you, and that's how therapy techniques are discovered, right? Are using them on the people that need them. And I think that that's where this Speak Out program is being kind of the latest and greatest tool. Not to say that LSVT is not a good tool, but this one definitely encompasses more of the cognitive linguistic skill as well. And that's why I really like to use it with my patients. And I have people that have had really great results with it as well. I saw somebody type a question about, is there a loud crowd group? And as I said, yes, I'm hosting one now virtually with 6 people. And I'm more than happy to start a second group. If we have interest of 3 or more people, I would start a second group, and I would do that virtually at another time of the week. Currently, we meet on Wednesdays at 1 o'clock in the afternoon. We were meeting live until COVID, and then we took that class to virtual. So in the interest of keeping everyone safe.
Tracy, I'm sorry, I had to jump off and take a call. You did mention, I hope, that you're able to do this virtually, right?
Yes, yes.
Great. Okay.
Yeah.
So I do the loud crowd is virtual right now, and I can definitely do any therapy. I will tell you that in my practice, it's been kind of strange. People want to keep coming into the office, and so I've been able to see everyone live, but I do have that option.
Yeah, and I think, with the threat of additional restrictions coming down,
Closures are coming.
a virtual option for speech therapy is great, and there's not many out there that are doing it, and that's why I bring it up.
Yeah, for sure.
Yes.
I will say, though, that Medicare was extended to cover telemedicine, and that happened because the Trump administration had declared a medical emergency. And so part of the benefit extended through Medicare was telemedicine. And my understanding is that that is going to be rescinded soon. And so with the new administration coming in, what I understand from the American Speech and Hearing Association is that will not be renewed. It will not be continuing. So if that's the case, I can take Medicare for the sessions in the office, but I won't be able to take Medicare for the online telemedicine, which there would be an out-of-pocket fee. And I would have to have someone sign a waiver to say that they understand that. That is my understanding as of yesterday from the American Speech and Hearing Association. So reimbursement is changing a little bit with the new, yeah, I feel you, John. That's right. That's coming with the new administration.
Okay, thank you. Okay, do you have time for one last question? It looks like somebody just asked
I do.
one.
I love questions. Bring 'em
Okay.
on.
Is there any, thank you. Is there any impact on voice to have Barrett's syndrome?
Barrett's syndrome is a GI disorder called Barrett's esophagus. And it depends on the treatment that the person has undergone for Barrett's. I've seen plenty of patients with Barrett's that have had parts of their esophagus removed, or they've had different things done, or they've had like a dilation. So it depends on the treatment for that. It can certainly, because of the level of reflux that usually comes with Barrett's, people can have hoarseness because of reflux. So I have seen voice disorders co-occurring with Barrett's, yes.
Okay. And there may be one last comment.
Okay.
Beth Ann.
It didn't say that to me.
Okay.
You're the one who's doing fine.
Okay, does Beth Ann, do you have a thought or comment? I saw your hand raised.
I wasn't sure if this is all
Okay.
you.
Perhaps not. Okay, well, thank you so much, Tracy. I will be emailing all of you the recording of this webinar. And please contact Tracy for further information and be safe. Everybody have a wonderful afternoon and holiday season. Thank you, Tracy. Thank you, everyone. Bye.
You're very welcome.
Thank
And sorry for the few little technical glitches that we had there.
No problem.
It seems like those things kind of follow me.